طيب بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. I would like to thank the co-chair and the audience and the organizing committee and my team in the society who invited me, and also the audience online. So I'd like to start by saying that I have no disclosure, and okay, so I have no disclosure. And in the next 20 minutes or so, I will introduce the topic by a case and review definition. Again, I discuss the clinical practices and the highlight changes from prior guidelines that was published in 2019. Then we'll review the current MDR tuberculosis profile in the kingdoms and the way forward. And hopefully we have time for all of that. So actually, this case is not my case. It's the case of Dr. Reham Kaki. She saw the case in one of private hospitals. And the case is about a 31 years old Saudi physician. Her past medical history is significant for antiphospholipid syndrome. She had 2 abortions. Other than that, she was fine. Presented with a fever and pleuritic chest pain for about 8 days prior to her presentation. For some reason, in other hospitals, was giving clindamycin. When she's seen by Dr. Hamkaki, she had a couple of differential on top of that was tuberculosis and bacterial infections, aspergillus, and other autoimmune diseases such as Wegener granulomatosis. Part of her workup, she had the CT chest that shows cavitary lesions. So the patient workup was positive for gene expert and smear as well, and also rifampin resistance were detected. She was started based on the rifampin resistance on INH, ethambutol, prisonamide, and was added linezolid and moxifloxacin to support the resistance to rifampin. And although clinically she was improving and some slight improvement on CT, her culture was sent to center in Dubai for susceptibility of first and second line. And it showed that it was resistant to almost all the drugs in the first line except to except to the ethambutol, and also resistant to fluoroquinolone that the patient was on. So briefly, I'm going to review the mechanism of a common mechanism of multi-drug resistance. So we know that rifampin resistance is associated with the RPOP mutation. So detecting that, it's highly sensitive and specific. And INH is INH-A and CAT gene mutations. Again, it's very specific and sensitive. A mechanism of resistance to prisonamide, usually mutation at PANC-A. And it's, again, sensitive and specific when you detect that. So it helps with the rapid diagnostic. And we know that the quinolone, usually the mutation at the gyrase. Okay, so based on that result, the patient was switched or continued on amikacin and bedaquiline, and the total duration of for 18 months, and she improved on that. So we'll use this case as a base for the talk now. So starting by definition, so we know that WHO currently in the last couple of years start defining the spectrum of drug-resistant tuberculosis to 3 major categories, which is multi-drug resistance, pre-XDR tuberculosis, and XDR tuberculosis. So I don't know if the pointer, again, okay, so it's the arrow. So MDR, it's rifampin resistance, mainly rifampin, plus some minus INH. So if INH alone was detected, it will call HR tuberculosis, but with the things we really care about is the MDR. So rifampin plus some minus INH, then we'll call it MDR. So rifampin is the base. Pre-XDR, if we have rifampin resistant plus fluoroquinolone and and the injectable. So if we have that, rifampin resistant plus fluoroquinolone resistance, we call it pre-XDR. So based on this definition, Dr. Reham case was pre-XDR tuberculosis. So what is the XDR? So when we have the rifampin resistance and the fluoroquinolone plus bedaquiline or linezolid. So I like this slide because it shows how historically we used to deal with multi-drug resistant regimen. So usually what we do, we take whatever the patient's susceptible to, for example, prisonamide, ethambutol, and we must corner it or support it by moxifloxacin or levofloxacin plus injectable like amikizin. And in order to build 5-6 drugs on the regimen, we either use BAS or linezolid or ethanolamide based on availability. And only if patient fail or did not tolerate, we move to bedaquiline or clofazimine or delanamide if it's available. So this is how historically we've been managing MDR. So starting with the clinical practice guidelines that done by the American Thoracic Society and endorsed by IDSA and the European Society for Respiratory and CDC, they started the guidelines with diagnostics. So we'll have just 2 quick slides on diagnostic before we dive into the therapeutic. So for diagnostic, rapid diagnosis is very important, and to identify susceptibility and preferably by genes, it helps. So looking at the available methods or diagnostic techniques that are available in the market, you can see the first half of the cycle, the blue one, it's what WHO put a lot of emphasis on their guidelines. And the second half of the circle, the light yellow, it's where emerging technology under development. So you can see the gene expert. We all know the gene expert. We really like it, and MOH keep endorsing and trying to build infrastructure, empowering hospitals and regional labs with gene expert. So gene expert have changed in the past years to gene expert ultra. So to enhance the sensitivity in smear negative, so it detects lower DNA in the samples, and it's work well in HIV patients. And most of you that it came recently to my knowledge that the Ultra has extra the cartridge to detect XDR, so it can test for INH, it can test for fluoroquinolone, and which is very important, as we're gonna see shortly. So please make sure that if you have gene expert, that you ask for the cartridge that detect INH and fluoroquinolone as well, and amikacin as well. Moving to the second technology, which is LAMP TB, which is very rapid. It's shorter duration, turnaround time 1 hour, because it doesn't use a lot of cycle and it's same temperature. So it's a loop amplification isometric technique. So again, it's recommended by WHO. And the good things is about it, it's just you put you add to the samples fluorescence, and you can detect it under ultraviolet rapidly. The other test is the TORNAT MTB, which is very important for initial diagnostic. They said it can replace a smear and culture. For me, no way we can replace culture. We always need susceptibilities. The last one is the line probe assay that can be used in direct or indirect samples, so direct from patient samples or from the culture for our susceptibility and identification. The one I start to be a big fan of, and I wish that we can have it available when we investigate outbreak of TB in a correctional facility, is the gene expert Omni, which is can act as point of care testing. It can mobile, you can take it in the clinic, you can take it, so it's very good. And the other one, which is another POC NAT, it's simple. It detects the component in the cell wall of the mycobacteria, lipoalbumin, in the urine samples. And for sure, we all know the sequencing. So it will be good if we all know sequence, but it needs certain infrastructure. So it can be either whole genome sequencing. And I heard one of the center in the state, they do whole genome sequencing for all suspected isolates, and they have susceptibility right for. So maybe then they can cut culture. Or you can do specific look gene like PANCA-A gene for pyrazinamide. Okay, so we finished the diagnostic. Now we dive in the therapeutic. So looking at the clinical practice guidelines, so they emphasize on individualized treatment and monitoring. So not one size fit all. And they always highlight infection control. So I'm an infection preventionist. So not to stigmatize the patient, but to cut the transmission and to try to control TB. Also, the guidelines based on the 21 PICO questions framed by the population, intervention, and outcomes, and they graded the quality of evidence and degree of benefit and risk. And also they did the propensity score, which I like that a lot, because propensity score helped them adjust the priorities or which drugs should be number one on the regimen based on the host, for example, HIV, immunocompromised, and the burden of the disease if the patient has cavitary lesions and high burden of the disease. So you can see here, they used meta-analysis of 12,000 patients from 50 studies from 25 countries. And you can see how it moved. You can see that let's go back because the mic. Bedaquiline and fluoroquinolone and the linazolids move up green. So those up in the green, that's mean this is priority. This should be in your regimen when you're dealing with MDR and XDR treatment. While the one in orange and in red, it should not be excluded. So you can see that no longer kanamycin, PAS, or ethanamide, capromycin, it should be started unless like you don't have resources, but and especially amoxicillin, clavulanic acid, macrolide. So all these came out. And why they decided that? So that the meta-analysis looked at the outcome. So those who improved clinically and microbiologically, as well as associated with a lower mortality. So before we start, so when we treat, the objective of treating tuberculosis is that you want something to hit the rapidly growing population of mycobacteria to cut the severity and transmission, and you want to eradicate persisting bacilli to achieve cure and prevent relapse. So that's why we have the intensive phase and the continuation phase. So the goal for the intensive phase is to reduce the bacillary load and resistance, while the your continuation phase is meant to prevent relapse. So it's acting on non-replicating and prevent relapse. And we put this in mind when we choose the regimen. So again, we need to understand what we're replacing. So the rule of your first line drugs, we have INH, rifampin, and quinoline, which is bactericidal activities. And we have the rifampin and pyrazinamide, we have huge sterilizing power. So when you replace that or it's resistant, you need to put in mind, you need something equal. However, for ethambutol, it's just bacteriostatic. It's there just to make the drug last longer, make it harder to develop resistance. Okay, talking now about the mono-resistant. Usually, we don't think a lot about mono-resistant INH. We think it's easy, it's simple. However, there is a study showed there is a delay and there is under detection of INH resistant. And as per WHO, there is 1.4 million in the world resistance to had a mono-resistant to INH. And they predict in systemic review that there is this associated with 3-fold increase in poor treatment outcome and 6-fold increase in acquired TB drug resistant. So they said when INH is resistant, this will predict that this isolate is capable to have more resistance in the future. So when you detect it early, you will be able to manage earlier. And also I like this study, observational study by European team. They looked at their patients between 2002 and 2014, and they had on the group 187,000. And that was a patient who had susceptible INH, and about 7,500 patients who had INH resistance. And they found that those who had INH resistance, they had a lower success in treatment compared to those who had INH sensitive isolates. So how we treat usually, it's simple. We add levo or moxifloxacin and to substitute INH. And this regimen will continue for 8 weeks. Then we continue on 18 weeks of rifampin and fluoroquinolone. طبعا we said it's individualized medicine, so it's based on the severity and cavitary lesion. We may need to prolong more if the patient did not respond, but this is the minimum duration. Okay. Again, this, I'm not going to go for the sake of time a lot on this slide, but you have the QR code so you can access it. I just like this, give me a visual map, which drugs is staticidals, what I'm going to replace, how can we recommend, and so on. So now we move to treatment of MDR and shorter regimen. We start with the shorter regimen. So bedaquiline, pretinoid, and linezolid. So BBAL regimen, the regimen that endorsed by WHO and by the CDC. So what do we know by bedaquiline? Bedaquiline, it inhibits Mycobacterium energy. It's the first member of its class. It's a bactericidal, and what I like most about bedaquiline, it's because I believe in stewardship, and my team here knows how hard we fight for shorter and narrow spectrum. So bedaquiline has this very narrow spectrum, so it's only Mycobacterium. Can we develop resistance? Yes, you can see resistance when you have mutation at ATPE genes, and it also by drug efflux. For pretinoid, it's going back to bedaquiline. So the major side effect is nausea, and it can prolong a QT, so if the patient at risk. Also, there's case report of chest pain and joint pain associated seen among those who started on a regimen that has bedaquiline. Pretinoid, it's a nitrominidazole class. It was approved 2019. It inhibits the cell wall mycolic acid biosynthesis, and also inhibits the cellular aspiration. It's good about pretinoid. It's work on replicating and non-replicating. So it's very good. It has very important role during the intensive phase. So for the side effect, pretinoid, again, nausea, vomiting. There is a headache and acne. And a patient will have a lower blood sugar on it. And there's case report of nerve damage as well. So linezolid, we only know linezolid. It's cidal for Mycobacterium, and it's inhibit protein synthesis. Okay, so moving on looking at the trial that support the BBAL regimen, starting by next trial. So next trial is an open label single group study that was done in 3 African sites, investigated the treatment with 3 oral regimen, 3 oral drugs, bedaquiline, pretinoid, and linezolid for 26 weeks, 6 months, in patient with XDR and MDR, and they follow the patient clinically for another 6 months after stopping the treatment clinically and microbiologically for outcome. So what they found, it was intention to treat population. So they have 109 patients, and out of that, 98 patients has cured, favorable outcome. Only 11 or 10% had unfavorable outcome. So this is intention to treat analysis. When they did modified attention to treat analysis, it was number of death 6 and withdrawal 2. However, they said that it was manageable. The side effect was, sorry, I went back. Yes. Okay. So they said the side effect was manageable, and the study or the trial was terminated earlier. So looking back in details on the side effect, it was mainly related to linezolid. And all the drugs or all the discontinuation or treatment interruption was due to linezolid side effect. 81% of the patient developed neuropathy. 48% develop hematological toxicity like bone marrow suppression, and 46 had resumed at lower dose, and 30% permanently discontinue linezolid. Then after the next trial, the next trial done by the same group, looking at different doses of linezolid with the same backbone, with bedaquiline for 26 weeks. And the doses is 200 milligram daily for 8 weeks, then 100 milligram daily for 18 weeks, plus pretinoid, 200 milligram for 26 weeks, and different linezolid doses. So a group took the previous 2 drugs with linezolid at the dose of 1,200 daily for 26 weeks, and another group took the same dose for 9 weeks, and another group took 600 for 26 weeks, and another group took the 600 at 9 weeks. And they again, a modified intention to treat population, they followed the outcome clinically and microbiologically. So what they found that all patients completed the full regimen, 93 and 93.4%. 89% of the patients on all regimen had favorable outcome. But you look closely, you'll find that patients who received bedaquiline, linezolid, bedaquiline, protonamide, and linezolid at 600 for 26, the whole 6-month period had a higher success and 91%. And finally, the third study that supports the BPAL regimen, it's the TB Practical. So this trial showed much improved treatment success rate with the BPAL regimen. So they had bedaquiline, protonamide, and linezolid, but the addition was different. So either BPAL alone, so that was arm, or BPAL plus clofazimine, or plus moxifloxacin. And the last one was the standard of care. So they found all BPAL-based regimen has a better success rate compared to the standard of care, 89%. And the one with the moxifloxacin was the highest. Okay, so this talking about treating pulmonary tuberculosis, not disseminated, not CNS infection, with shorter regimen, 6 months, using BPAL regimen base with moxifloxacin. It was endorsed by CDC and WHO as highly recommended. Now, experts can use this regimen. There have been several scattered studies looking at using the short regimen 6 months for BPAL in extrapulmonary infection, but this needs expertise and it's not supported by randomized trial yet. Okay, now how we treat the MDR, like when you use a longer regimen for extrapulmonary or disseminated disease, we have Group A. Under Group A, there is levofloxacin, bedaquiline, linezolid. And Group B, we have clofazimine, cycloserine. And Group C, we have the ethambutol, dylanamide. I would like to highlight that kanamycin, cabromycin is no longer in any protocol. So before Dr. Mugbil cut me, so this is the last slide, then I will run quickly through the Kingdom profile. So current approach to build multi-drug resistance. So we need 5 drugs, preferably guided by susceptibilities, or we have that the patient never been on it before. Then we have to use fluoroquinolone. Now, going to levofloxacin, moxifloxacin, I had discussion with our clinical pharmacist in the ICU, Dr. Badura Dosari. So what are the different, can be different? So it's for working against tuberculosis, there is not much different. However, if you have a patient with a QT prolongation or at risk, it seems levofloxacin safer in that patient population. So we use fluoroquinolone, then bedaquiline plus linezolid, clofazimine plus cycloserine. So you need all those. And maybe if you need injectable, but we try to stay away from injectable, or you like amikacin, tryptomycin, or you use dylanamide, prisonamide. You can see also you can see also imipinum and meropenem on the table. So the trick, because I'm not going to go over it for the sake of time, but the trick with the meropenem for TB, it always you need to combine it with the clavulanic acid. All the studies said it needs clavulanic acid to reach its potential cidal and sterilizer. So in case of that you don't have it, you can use amoxicillin clavulanic acid. This is written by the WHO to support meropenem. But augmentin or amoxicillin clav, it's not anymore used by itself to treat MDR, but as a combination of meropenem to reach the sterilization. And so you need 5 drugs in the intensive phase and 4 drugs in the continuation phase. And based on MDR or XDR, you either the total duration of treatment will be 18 months or 24 months. Okay, moving to the profile, we published early this year the Kingdom, the epidemiology of tuberculosis in Saudi Arabia from 2015 to 2019. And I just want to share with you that the susceptibility among our isolated Saudis, it seems to be improving, or we're detecting better, we're diagnostic better. However, the data promising, we don't have high rate. However, we don't have very strong infrastructure in all the labs to detect resistance. So we have to balance clinically all the time. So quickly, this is how you can see in numbers, the number of multi-drug resistance and rifampin resistance. So for example, in 2023, we have 32 cases that were resistant to rifampin. Out of that, they had other combined resistance, like 10, they had MDR, they were MDR TB. And here you can see the distribution by region. This is, I believe, 12 regions that reported in the last 5 years resistance, rifampin resistance. And here 9 regions that reported MDR resistance in the last 5 years. And as we see more pulmonary TB among male, the same, we see more resistance among male compared to female, the same for MDR, male more than female. In terms of treatment success rate in the kingdom, we have improving success rate, and our report this year, inshallah, will reach 90 success rate. This is total MDR and susceptible isolates. We do have a lower mortality rate, but this is not specific for MDR. This is susceptible and resistant. So in conclusion, all forms of drug-resistant tuberculosis and susceptibles are highly transmissible. So we really need to, in order to eliminate tuberculosis from our community, we really need to act fast, diagnose, suspect, and isolate. It has higher mortality and morbidity, and we know that it's associated with the long-term effect on the lung and damage. Rapid diagnostic and susceptibility testing is crucial, so we always have to work on the lab infrastructures, and we know what we're testing and what we're missing. So if the lab reported rifampin resistant, we need to ask, are we looking at the INH? I'm sure INH is susceptible or not. Bedaquiline-based regimen is promising in the state of art nowadays. The fluoroquinolone linezolid are the cornerstone for that. Duration 6 months is good, but for now, evidence is strong for pulmonary tuberculosis. We always, we're promoting a shorter regimen, but it's individualized medicine. We look at the medicine. We transition away from injectable like capromycin. However, this challenge and limitation depends on the drug availabilities. TB drug resistant profile in the kingdom is the resistance declining, but we need for sure more effort to be done to reach the elimination by 2035. And by this, thank you very much.